Hello, this is Jeff Swenson coming to you again from Salt Lake City. I'd like to provide another lecture on blocks at the level of the ankle and above. We're actually going to focus a little more on providing blocks at the mid-shaft of the lower extremity. The reason for this is that sometimes when we are wanting to perform an ankle block, we either cannot access the ankle because of surgical dressing, or there is cellulitis or infection at that level. So it's nice to be able to isolate these same nerves at the mid-shaft of the lower extremity as well. So we will proceed in that fashion. The first nerve we will talk about is the superficial peroneal nerve, followed by the deep peroneal nerve, the sural nerve, and lastly the tibial nerve. Starting off with the tibial nerve at the level of the ankle, what we have is a fresh cadaver dissection of the medial aspect of the left ankle, and we can see the Achilles tendon, the medial malleolus, the tibial nerve, and the tibial artery. Now the flexor retinaculum usually extends down and covers the tibial nerve and tibial artery, but in this case we have cut it away so you can see the relationship between the tibial nerve, which is posterior to the tibial artery. As we go in for a little bit closer view, you can see where the flexor retinaculum, the fibers above, go anterior and posterior, and those fibers have been cut to show the relationship between this vessel and this nerve. If we look at the ultrasound at the level of the ankle, these relationships are the same, namely the tibial artery and tibial nerve relative to one another. The tibial artery is anterior to the tibial nerve. We also see in this image the flexor retinaculum I've shown here by a straight line. When we remove that line, the arrows indicate the fibrous tissue that overlies the tibial artery and tibial nerve at the level of the ankle. Now as we move more proximal on the leg, we see that the relationship between the tibial artery and the tibial nerve is maintained. Namely, the tibial artery is anterior to the tibial nerve, and both structures are contained deep within the investing fascia of the lower leg. The flexor digitorum longus is anterior, and the flexor hallucis longus is posterior. Next, we'd like to talk about the sural nerve. The sural nerve at the level of the ankle lies between the Achilles tendon and a confluence of the peroneus longus and peroneus brevis. A real easy landmark to find the sural nerve at this level, if we image between the lateral malleolus and the Achilles tendon using a very light touch with the ultrasound transducer, is the small saphenous vein. The small saphenous vein can be found immediately adjacent to the sural nerve. And here, once we know what we're looking for, we can see the nerve with its fascicles. Much as other nerves, the sural nerve can be traced proximally, but it has kind of a surprising course. So if we look at a fresh cadaver dissection, we can see that the sural nerve passes from the lateral malleolus position over the Achilles tendon to a position running up the midline of the calf posteriorly. And it comes to perforate the investing fascia of the leg between the lateral and medial heads of the gastrocnemius. This is an ultrasound image at the mid-shaft of the tibia, showing on the ultrasound the lateral head of the gastrocs, the medial head of the gastrocs, and the small saphenous vein, accompanied once again by the sural nerve. This is immediately prior to it piercing the investing fascia of the leg. The deep peroneal nerve is unique. We used to use surface landmarks, namely the extensor hallucis longus and the extensor digitorum longus to find this injections point. In this particular dissection, the extensor retinaculum, which is a tough fibrous tissue that normally overlies the deep peroneal nerve and the anterior tibial artery, has been removed so that we can demonstrate this for you. So once again, other surface landmarks, the extensor hallucis longus medial to these structures, and the extensor digitorum longus lateral to these structures. And the tibial artery medial to the deep peroneal nerve. Similarly, if we look at ultrasound images of the dorsum of the foot, we can see that the extensor hallucis longus is medial to the vessels in the nerve, and the extensor digitorum longus is lateral. The deep peroneal nerve and the anterior tibial artery both lie right on the surface of the distal tibia. So when you're doing this block, the needle will usually abut against the periosteum of the distal tibia. But this nerve can be blocked either between the anterior tibial artery and the deep peroneal nerve, or lateral to the deep peroneal nerve. There's a unique relationship between the anterior tibial artery and the deep peroneal nerve in that it also travels proximally with the artery. If we look at this level here, we're looking at, again, the midshaft of the lower extremity, and we see on the right of the screen the tibia, and the muscle in this anterior compartment is the tibialis anterior. Between the tibia and the fibula is an interosseous membrane, shown by the arrows here. The interosseous membrane can be bowed as the patient flexes their foot, dorsiflexes and plantar flexes. You will see this interosseous membrane bow in and out between the two attachments on the tibia and the fibula. It's very difficult to see the deep peroneal nerve at this level, but it does run in close proximity to the anterior tibial artery, so you can do an injection, a field block around the anterior tibial artery to successfully block this. The superficial peroneal nerve is very interesting in that in the past we used to perform this block by doing a field block in the subcutaneous tissue between the lateral malleolus and the medial malleolus. Interestingly, we can see how much this nerve fans out as it just above the ankle and then coalesces very tightly as it approaches the midshaft of the lower extremity, and it actually pierces the investing fascia of the leg at about the midpoint of the fibula. So we're looking at a lateral aspect of the right leg here. The nerve can be blocked at this level with about 2 to 3 cc's of local anesthetic. Here is the ultrasound image of this unique anatomic structure. We find this by first looking for the fibula. We find the fibula, and there's an anterior spine on the fibula, and if we follow that spine out, it gives way to the anterior intermuscular septum. This anterior intermuscular septum separates the anterior and lateral compartments of the leg, with the posterior muscles being the peroneus brevis and the anterior muscles being the extensor digitorum longus, as shown here. As we follow the anterior intermuscular septum out, the superficial peroneal nerve lies just on the posterior border of the anterior intermuscular septum and just deep to the investing fascia of the leg. So those 3 arrows that you see there pointing to that little triangular structure is the superficial peroneal nerve.